Thank you very much, Mr. Chairman. I am really honored by being present here, giving the introductory or the opening lecture about adaptation of international evidence-based guidelines. أحب أشكر الأستاذ دكتور عبده سعيد، الأستاذ دكتور محمد صلاح، دكتور شريف شاذلي، وكل القائمين على المؤتمر لدعوتي إني أكون موجود مع حضراتكم النهارده. اختيار الأستاذ دكتور عبده سعيد للأدابتيشن اوف انترناشونال ايفيدنس بيزد جايد لاينز بيعكس اهتمامه الشديد إن احنا يكون عندنا في مصر جايد لاينز نقدر ننظم بيها المهنة الطبية for the benefit of the practice and for the benefit of our patients. Thank you very much, Professor Abdu, for inviting me. Let's start from the scratch, as they say. What are the guidelines? Guidelines are defined as statements that include recommendations intended to optimize patient care. These recommendations are informed by systematic review of evidence and assessment of the benefits and the harms of alternative care options. From long ago, we used to have opinion-based guidelines, but the whole world has shifted currently to what is known as evidence-based guidelines. These opinion-based guidelines was only reflecting the expert opinion. They were inexpensive in their generation, but they had a very high potential of bias and hidden conflict of interest. And Antman et al. In 1992 discovered that the expert opinion does not always reflect the state of the current medical knowledge and the best practice. But on the contrary, evidence-based guidelines are systematically developed statement according to strict methodology. They have a very strict methodology. It includes systematic literature review, searching for every bit of evidence that has been generated anywhere in the world. And it is generated mainly from well-conducted scientific research, excluding the badly conducted scientific research. That's why they are less susceptible to bias in their conclusions. Every one of us knows that we are having leaks from research into practice. Glasgow in 2005 found that only 20% of the very valid and important evidence that is generated by the studies reach our patients. And 80% of this valid research, important research that is directed to the benefit of the patient, is lost in the medical practice. And that's why there is an importance for having evidence-based guidelines, because these guidelines identify all the treatment options and it prioritizes them. They put the risks versus the benefits and the costs. They consider all of this, and they minimize an unacceptable variation in practice. And also these guidelines will put a quality standards upon which we can measure our service that we give to our patients. And finally, it improves the patient outcomes in terms of morbidity and mortality. How to develop guidelines? Before I go into adaptation of international guidelines, we should understand how do guidelines are developed in order to appreciate the importance of these guidelines and how does they improve the practice and the patient care. These guidelines need a very large investment of resources. Every guideline takes a long time, about 1 to 2 years to be developed. They need trained personnel on specific skills, such as expertise in the guideline generation, skills in searching for the evidence, skills in evaluating and critically appraising the evidence, skills in working in small groups and leading small groups, and of course, information management. This is the Scottish Intercollegiate Guideline development process of the guideline, and this is an international process for developing the international guidelines. Let's see how rigorous and very important it is. The guideline development passed by 11 stages, from the topic selection to development of the team that is going to put the guideline, to defining the purpose and the scope of the guideline, to identify the most important and the key questions that we need an evidence for, to do systematic literature review to find all the studies that are pertinent to the guideline at hand, to quality assessment of this research, to include the high quality research and exclude the low quality research, to grading the recommendation, high, moderate, low, or very low, to consultation and peer reviewing to get opinion of everyone who is concerned with the guidelines, to implementation of the guidelines, to auditing, reviewing, and updating. And I'm going to pass through the whole process. The topic selection, international guidelines are usually topic of the international guidelines. I prioritized according to diseases of national priority, perhaps, or diseases that affect large number of the patients, or diseases that have controversies and variation in practice to regulate the practice, or diseases with poor outcomes, or the disease that consume a lot of resources. They put guidelines to regulate the practice in these areas. Then they formulate the guideline development team. And this team includes hundreds of experts in guideline generation and in the different specialties concerned with the guideline. They would have EBM experts, which is the permanent staff of the guideline generation. They will have clinical experts from all disciplines dealing with the condition at hand, from clinicians of various disciplines, to nurses, to pharmacists, to dietitians, to physical therapists, to policymakers, to economic analysts, to bioethicists, and they never forget to have representatives of consumers or the patients themselves. They are having very well-trained patients on guideline generation. They participate in the generation of the guideline because they are the end user of the recommendations of the guideline. Then they start to put the purpose and the scope of guideline. What is the condition that we are going to deal with? What are the type of the care providers or the user of this guideline? Are they the obstetricians, the gynecologists, the anesthetists, the surgeons, or whatever? What are the type of patient and inclusion criteria and their presentations? Are we going to put a guideline for diagnosis, or prevention, or treatment, or all of this? What are the different investigation modalities that may play a role in this condition? What are the different treatment modalities that we need to find an evidence for? What is the clinical setting in which we are going to use or to apply this guideline? Is it a primary health care center, secondary health care establishment, or a tertiary health care establishment, or all of this? So after putting the scope of the guideline and the purpose of the guideline, they start to put hundreds of key questions, very small questions. If any one of you worked in evidence-based medicine, he is for sure familiar with the PICO question. They put hundreds of PICO questions. Each question searches for a very small information that will be turned into recommendation at the end stage of the guideline generation. The conditions will be divided into key PICO questions about prevention, diagnosis, treatment. All treatment options, medical treatment options, are searched, or surgical treatment options are explored, dietary treatment options, exercise, etc., with the benefits and the harms of each modality, either diagnostic or therapeutic modality. These hundreds of PICO questions are given to different groups. Each group has only one question. They start systematic literature search and the literature review. They look for every bit of a study on this specific, very small question. I was doing a Cochrane systematic review about gonadotrophins for male subfertility, and I ended up having more than 2,000 researchers sent to me by the Cochrane group to start to screen and to select which studies I am going to put in the systematic review. That's why it is important not to miss a very small bit of evidence published anywhere in the world. They do electronic search for studies from all available databases, like the PubMed, the EMBase, the SINHAL, any electronic database. Even the non-indexed journals, they do hand searching in the non-indexed journals, and they always search for unpublished data. the theses, dissertations in the universities, conference abstracts and the proceedings, the gray literature, and they even contact the known publishers if they are having a study that was not published till now. The aim of this very meticulous search is never to miss a result that has been published or even unpublished anywhere in the world. After that, they start a very meticulous methodology for quality assessment and critical appraisal of every study they found. They apply explicit criteria for selection of the studies to be included, quality assessment and the critical appraisal to evaluate the selected studies, then inclusion of high-quality studies in evidence generation, and finally, they generate for every small PICO question a systematic review, a meta-analysis, and they put what is known as evidence tables. So we are having tens of systematic reviews and the meta-analysis that form the skeleton of this guideline. And also these systematic reviews and the meta-analysis are the product of hundreds of researches done all over the world with thousands, multiple thousands of patients participated in these researches. Then they start to level the evidence and grade the recommendation. If they are having evidence from randomized controlled trials or systematic reviews of randomized controlled trial, they call it level 1 evidence. And when they draw a conclusion or a recommendation from this evidence, they give it a grade A recommendation. If they are having evidence from observational study like cohort study, they put it level 2 evidence and the recommendation is grade B recommendation. If they are having evidence from a case control study, which is an observational study, the evidence is level 3 and the grade of recommendation is still level B because all observational studies, they put it in level B. If they are having evidence from non-analytical or non-comparative studies like case series, they give it level of evidence 4 and grade of recommendation C. And only in absence of all research, there is no research on this question, they start to get expert opinion by a process known as Delphi method. This expert opinion, they should reach consensus by Delphi method before getting the recommendation. They put it the least level, which is level 5, and the least grade of recommendation, which is the recommendation D. So they grade the recommendation and they level the evidence. Another very important category for quality grading of randomized of controlled studies, which now we can see published in many journals and systematic reviews, which is the 4 circles and the 4+ inside. If they have a very high evidence, they said that this is a very high quality evidence, which means simply that further research is very unlikely to change the evidence or the estimate. And they give it 4 circles with 4 pluses inside. If they are writing, this is a moderate quality evidence, this means that further research might have an impact on the estimate, and they give it 3 circles with plus inside and 1 empty circle. If they are saying that this evidence is of low quality, this means that further research is likely to have an effect on the estimate and the more research is still needed here. They give it 4 circles, 2 of them only filled with the plus sign. If they are having a very low quality evidence, this means that this evidence or this estimate is very uncertain. Most likely it will change with more research and more research. So they give it 4 circles, only 1 with 1 plus. But here, does this mean that the low quality evidence or low evidence I shouldn't follow? No, you should follow, because even if it is a low quality evidence or very low quality evidence, this is the best evidence that we are having currently. Wait till it changes and it changes the practice, but use it currently because we don't have any other evidence. Then after finishing the grading of recommendation, they write down the initial draft with all the recommendations, and they ask for consultation and peer reviewing. This consultation and peer reviewing process aims at widening the participation and making a sense of ownership. Every one of the practitioners has seen this guideline. Everyone had the opportunity to say his or her opinion, so there is a sense of ownership. They also get feedback from those who consulted and peer reviewed the guideline, and then look at the feedback. Can we incorporate anything from this feedback in the guideline, or it doesn't matter, it doesn't need it to be incorporated in the guideline process? And this is done by the SIGN, or the Scotch Intercollegiate Guideline Network editorial process. After the consultation and peer reviewing and finalizing the guideline, they start publishing the guideline and the dissemination of the guideline, so that everyone in the community, not only the physicians, but the patients even, should know about the new guideline, so that everyone is aware that we are having some changes in practice and the best practice is present for this condition. Guidelines are published in the journals, in electronic media. Guideline dissemination is pursued in the media, and every one of us know that they always having a medical part in the news outside, and they publish any new or advertise for any new innovation, any new discovery, or even any new guideline that has been published. In the media, in the conferences, in the workshops, in the medical internet forums, medical societies, newsletters, publication in professional journals, the most important is to make the guideline easily accessible to doctors and patients, and it should be distributed free of charge at the point of care, so that everyone has a copy of the guideline at his hands. After that, it is the phase of implementation of the guideline. During implementation, they watch what is happening in the medical community. They should identify the barriers against that prevent implementation of the guideline. Is there any structural barriers like financial disincentives, for example? Is there any organizational barrier that does not allow for implementing the guideline, like lack of facilities or lack of equipment or something like that? Is there any individual barrier like lack of expertise, lack of interest perhaps, or lack of skills? And we should know that implementation of the guideline is not simple. It is the most difficult part of the guideline process. To implement the guideline in practice, you have to overcome all the barriers before implementing this guideline. The final phase in the international guideline production is auditing and reviewing and updating. Every guideline is reviewed after 2 or 3 years, and any new evidence or any new research should be taken care of and incorporated into the new guideline if it is okay to be included. And that's why I call these guidelines, they are living guidelines. They always develop. There is constant review process. There is a regular update of the guideline. This is how do international evidence-based clinical practice guidelines are produced. A very important procedure that every one of us should be aware about it before we read the guideline, so that we can appreciate the effort done behind this guideline. This is the experience of humanity in this topic, the experience of all of the medical doctors and physicians in this topic. Not only the experience, it is the documented research about the topic. So there is no way to say, no, my opinion is to do so and so. Research has proved that this is best practice, this is the optimum for our patients, we should follow. Now we come to the adaptation process. We are having GEMS. These GEMS are the international guidelines developed all over the world. We shouldn't neglect them. We should make use of them. But we don't have to reinvent the wheel. We don't have to put guidelines once again from the scratch. we can use these gems and produce our own guidelines based on these evidence-based, high-quality guidelines. We have to use the ready synthesized evidence-based guidelines after modifying them to suit our local needs, our health problems, our own economic situation, etc., etc. Is this feasible? Yes. I put a slogan for this process which says, adopt and adapt. You have to look for the available guidelines on the condition, adopt one or more of these guidelines, and adapt it to your local circumstances. So always don't forget, please, to adopt and adapt. Because many times we hear that, does the international guideline they made for the USA is relevant to our practice, to work in our country? Yes, they are relevant if we adopted it and started to adapt it to our local environment and local circumstances. This is not an excuse to work without guidelines, I'm sorry. So they even gave us the methodology, a collaboration known as the adaptee collaboration. They worked together to put a methodology for adaptation of international guidelines for local contexts. What did they do? They published an article in 2006, which means that 17 years ago, we are having an article, How to Adapt to International Guidelines. They called it Adaptation of Clinical Guidelines, Literature Review, and the Proposition for a Framework and the Procedure. And they put a very important definition. What is guidelines adaptation? It is a systematic approach. It should be systematic. It have a strict methodology to the endorsement and or modification of guidelines produced in one cultural or organizational context or setting to be used in a different cultural and or organizational context. This is what we need. We need to transform those guidelines that are made for the USA to guidelines that are suitable for Egypt, for example. This is exactly what we need, and we are having the methodology. It customizes the already available existing high-quality guidelines to the needs of local users. Adaptation makes the guideline suitable to a particular country or health establishment circumstances. And this is published in 2006. But what is the adaptive methodology? Can we really use the adaptive methodology to adapt international? It's a very easy methodology, and quite sure that every one of you will leave this lecture knowing how to adapt the guideline. If not himself, for the hospital, and if not for the hospital, for the whole country even. This is the adaptation process. We have three phases: the setup phase, the adaptation phase, and the finalization phase. The setup phase is very simple. Establish an organizing committee. These are the people who are motivated to adapt the guidelines. They will be the organizing committee. Then select and prioritize the guideline topic. Which topic you want to work? Preeclampsia, diabetes with pregnancy, endometriosis, whatever the topic you choose to find guidelines to adapt. And check whether adaptation is feasible. Is there a will in the institution to adapt guidelines and apply it in everyday practice or not? Is it feasible, or I'm going to work and do effort without avail? Then you have to identify the necessary resources and the skills. I'm going to speak about this, and complete the task of the setup phase and the timeline for the adaptation. So establish the organizing committee, select the topic, and check whether adaptation is feasible, and then identify the necessary resources of skills. You need to have a project management team and administrative support of the guideline. Does the administration give you support to produce the guideline or not? If you have support of the administration that should support the guideline producers, you can start your work. Also, you have to have what is known as GWG, or guideline working group. And everyone in the team of the guideline working group should be committed. They should show commitment. And even the advice assigned commitment with time plan for meetings, face-to-face meeting, and revision of the documents at hand outside of these meetings. So commitment by the guideline working group members, face-to-face meetings and outside of meetings, to review all of the documents is very important. And you have to have people with skills in the specialty and the methodology of evidence-based guideline generation. And don't fear from the methodology. This is what I am showing you now. This is the methodology. It's very easy methodology, as you are going to see. They should be represented in the guideline working group. After putting the team and they show their commitment, you have to put terms of references, TORs, for the guideline plan, writing a protocol, putting the scope of the work to be completed, who are the members of the guideline team, and how often the panel should meet. This all of this should be written in a protocol so that everyone will follow the protocol. And if anyone has any declaration of conflict of interest on any topic, he should declare his conflict of interest for that topic. And they always agree that decisions will be taken by a consensus process. No one will be the most senior or the head of the group. So what I say is going to be done. No. There should be always consensus process in the decision making, especially when we don't find research covering a specific point. We should do some sort of meetings to reach consensus what to write in the guideline. And put the time plan at the completion of the preliminary phase. The guideline working group should write down the timeline for completion of the adaptation process, and they set a target date for the finalization of the guideline. This is the preparatory phase. Nothing has been done. It is just an agreement between a group of people and the administration. If they are having the will and the motive, they can start the adaptation phase or the adaptation process. What is the adaptation phase? First, determine the health questions or the domains they are going to cover in the guideline. Are you going to cover the prevention or the diagnosis or the treatment or the prognosis or perhaps all of this? You have to define what we are going to cover in the guideline, in the adapted guideline. And what are the questions you need to answer? And to tell you the truth, we look for the questions in the adapted guidelines, and we put our questions. We don't have to start from the scratch. We will agree that we are going to put a guideline for prevention of preeclampsia, diagnosis of preeclampsia, treatment of preeclampsia. What are the questions? These are the questions that are covered in the international guidelines. And if you have a question at mind that was not covered in the international guidelines, at that time we can put this question as an added question that we have to search for an evidence for. We put the domains that we are going to work, then start the process of searching for the guidelines. And when you search for the guidelines, you are going to get them, screen them to see what do they cover. And importantly, to reduce the large number of guidelines. It is very important to have 2 or 3 guidelines maximum to work for. Usually, 1 or 2 guidelines are enough, and sometimes only a single guideline. You will find all the needed data, and you are going to work with it. So it is importantly to reduce the large number of the guidelines. Where to search for the guidelines? The guidelines should be evidence-based, they should be from a reputable group of producing guidelines, and they should be recent within the last 3 years. Sometimes you don't find in the last 3 years guidelines, don't go beyond the 5 years. If you are having in the last 3 years, okay, well, and good work with them. If you don't have 4 years, 5 years maximum. If there are older guidelines, skip them and don't adapt to this topic. Wait till there is a good, high-quality international guideline. There are many bodies that produce very high quality guidelines, like the Canadian Medical Association in Canada, like the United States Preventive Service Task Forces, like the American College of Obstetricians and Gynecologists, the American Society of Reproductive Medicine, the Institute for Clinical System Improvement. All of these are in the United States. Then in Europe, there is the SIGN, or the Scottish Intercollegiate Guideline Network, the NICE, the National Institute of Healthcare and Clinical Excellence, the ESHRI, or the European Society of Human Reproduction and Embryology, the Royal College of Obstetricians and Gynecologists. And even in Australia and New Zealand, they produce very high quality guidelines. These are the remarkable issuing bodies of guidelines. In Australia, there is the National Health Council, Medical Research Council, and in New Zealand, the New Zealand Guidelines Group. Don't bother yourself searching in all of these and in other guideline issuing body. Go and have a trip in the TRIP database, www.tripdatabase.com, and write any word you would like to have guidelines for, or any disease, I mean, you would like to have a guideline for. You will find a lot of guidelines. Look here when I wrote in the TRIP database the word endometriosis. You can find on the left a lot of researches about endometriosis, and the one in the red rectangle, you will find the heading is guidelines. Guidelines, they wrote down what? In Australia and New Zealand, there is one guideline. In Canada, no guidelines on endometriosis. In the USA, there are 4 guidelines. In the UK, there are 3 guidelines. Other guidelines, there are 10 other guidelines. And on the right-hand side, you will find all of these guidelines present by their title and a small summary of the guideline written below. And if you clicked on any title, it will take you to the guideline itself. You can download it in PDF format and start reading and working with it. Here you can see endometriosis, guideline 2022, ESHRI, or European Society of Human Reproduction. Another one, prophylactic procedure associated with gynecological surgery for the management of superficial endometriosis and adhesions. These are clinical practice guidelines from the French College of Gynecologists and Obstetricians. So the guidelines are present, they are handy, you can download them, you can read them, you can use them. We have no excuses. There is no excuse whatsoever why not we are not having a guideline. Finally, we will agree as a guideline working group to work on these 4 guidelines. We'll put them in Tool 7 or in this table. What is the title of the guideline? Who is the publisher? What is the country? The publication date, and the end date of search. The last research study they found was on October 2019, for example. This means that all studies published after October 2019 are not included in this guideline. So if you are aware of a study that is more recent than the guideline search date, you may use it in your adaptation process. And if you are having any comment about the guideline, write it down here. So we searched for the guideline. Now it is the time to assess the quality of the guidelines. Usually there is a tool known as the Agree tool for assessing the quality of the guideline. But as a matter of fact, since you are having high quality guideline from very highly reputable issuing bodies who put the Agree tool, use them directly without going with all the hassle of assessment of the quality of the guideline. The guideline recency, it should be 3 years maximum, as I said before, and assess its content if you are having more than one guideline. Sometimes you find a specific guideline who wrote about something that is not present in the other guideline. Sometimes you can find endometriosis guideline, which deals with endometrioma, another one which deals with pain with endometriosis, and a third one that deals with surgical treatment for endometriosis, so you may use them all and combine them all to have a complete guideline about endometriosis. And assess the acceptability and applicability of the recommendations. This is a very important step, and let me say the most important one. We are having the recommendations. We have to look at them one by one. Is this recommendation acceptable to be applied in our population beliefs, preferences, and values? For example, the best treatment for severe azoospermia or male factor infertility is artificial insemination donor. Can we use this as a recommendation in our community? No. So this recommendation is not acceptable. I will not take it. The second is it applicable? Do we have the resources and the equipment and the personnel who can apply this recommendation? If yes, we are going to take it. If no, we are going to leave it. So remember, adopt and adapt, and remember the TRIP database, and remember acceptability and applicability. Adopt and adapt, TRIP database, acceptability and applicability. Then we are going to select the recommendations that we are going to include in our adapted guideline. And here, you can reject a whole guideline. I will not take any recommendation from this guideline. It is allowed. I can accept a whole guideline. I am going to take all of this guideline as such, and I will not modify anything. This is acceptable. Or you can accept specific recommendations from one guideline and other recommendations from another guideline. This is acceptable. Or you can modify a new recommendation to suit your local context. So you either take some recommendations from here and there and leave the others, or you modify the recommendations to suit your local needs and your local environment. And this is the second, the most important table in the adaptive process. This table shows what? What is the question or domain? The clinical practice guideline number 1 recommendation, what did it say? The second guideline, what did it say? The third guideline, what did it say? And finally, which of those you choose, or if you are having a modification, put them. And I am going to give you example. But before going to the example, this is a very critical and tricky situation. Please, if you are going to modify a recommendation, care must always be taken when modifying existing recommendations, not to change them to an extent that they are no more evidence-based, no more reflecting the evidence. They will be reflecting the opinion of those who put the guideline. We don't want this. We want all the recommendations to be evidence-based. Even if none of the recommendations suitable, and you are going to use a recommendation, you should bring it from research. This is very simple as this. Not, I feel that we should do so and so. No, there is no feelings here. There is no hunches. There is no opinions. Only scientific research. If we are having research in Egypt, please use it and add it in the modified recommendation. I choose one example to give you the feeling of how we do the adaptation. So we only choose the topic, search the guideline TRIP database, adopt some guidelines to adapt, and put them in Table 7 and in Table 8. We can see here that this is a guideline for cancer cervix, carcinoma of the cervix. In the screening, we are having a guideline by the American Cancer Society in July 2020, and a guideline by the American College in April 2021, and a guideline by the WHO in February 2021. What did these three authorities say about screening? The American Cancer Society said cervical cancer screening should begin at age 25 till 65. Women should have a primary HPV test every 5 years. And if you don't have a primary HPV test, you may do either co-test, which is a combination of pap smear and a less sensitive HPV test known as secondary HPV test every 5 years, or pap test alone, pap smear, every 3 years. The American College said that women aged between 21 and 29, so they started screening from 21, not 25, as the American Cancer Society, should have pap smear alone every 3 years. After that, between 30 and 65, should have any of the following: pap smear every 3 years, primary HPV test every 5 years, co-testing every 5 years. What did the WHO say? It said screening should start from 30 years of age in the general population of women, with regular screening with a validated primary HPV DNA test every 5 to 10 years, which recommendation we are going to take and use in our context. Are we going to take that of the WHO, or that of the American College, or that of the American Cancer Society, or modify the three to put something based on these three guidelines and three recommendations to suit our environment? This is the adaptation process. We may find 21 is very early. We would like to start at 30 like the WHO said. And we may find that DNA testing is not available and very costly. We would like to have the pap smear. So we may advise that from 30 or from the age of marriage in our community, every woman should be screened by pap smear every 5 to 10 years. And we may end up with a recommendation like this to use. This is all the adaptation process. من فضلكم ببساطة شديدة حددوا الموضوع، دوروا على الجايد لاينز في التريب داتابيز، اختاروا الجايد لاينز، حطوها قدام بعض كده واقعدوا مع بعض، ناخد دي ولا دي ولا دي، ولا نفصل حاجة جديدة. مفيش أكتر من كده، موضوع مفيش أبسط من كده والله العظيم، عشان ما يجيش حد بعد كده يقول إيه يعني هي بتاعة الأمريكان كانسر سوسايتي تنفع لينا في مصر؟ لا، احنا خدنا من الأمريكان كانسر سوسايتي حاجة، من الأمريكان كوليدج مثلا السن، خدنا من WHO حاجة، وهكذا، وعملنا our own adapted clinical practice guideline. Finally, this is the final phase and the final slides. External review، بعتوها لكل الناس تعمل لها reviewing so that they give you feedback and they have a sense of ownership. Consult with the endorsement body, with the departments that we are going to apply this guideline at. Consult with the source guideline developers. Some source guideline developers put a copyright, so you may ask their permission to use the guideline. And you have always to acknowledge the source documents by putting a statement that is very clear. This guideline has been adapted from the American Cancer Society guideline, so and so, and put the references of the guidelines that you have adapted. And the plan for the time of updating of the guideline, and to produce the final document. Having guidelines is never difficult. It only needs motivated people, dedicated staff, teamwork, and teamwork. And thank you very much for your attention.
Thank you very much, Professor Abdelhamid Atya, for your very interesting, comprehensive, and conclusive